There's not going to be anything new on this particular recording. So if you've seen it in the lecture and you understand it, if you want more, please proceed. I'm just going to kind of give you a reiteration of the theory here and a little bit of practice. And then I'm going to just throw in some of the reference materials you're going to see on the lab quiz. So first, I kind of found this alternative flowchart if this helps you visualize it better. I really like to do it with the values. So in the other acid-base imbalance video is kind of like my take on this, but if you like this and want to maybe keep a copy of it, I don't think it's terrible. I mean, it goes through the same thing. It just kind of doesn't have the actual values, which I do want you to know. And I actually think for your practice in the future, you should know these by memory, that the pH range for normal is 7.35 to 7.45. The partial pressure or just the concentration levels of CO2 are 35 to 45 millimeters of mercury. And the bicarb, this is the one that can kind of vary from source to source, but like just go with it. 22 to 28 milliequivalents per liter for this class. And the problem is, because we have compensation mechanisms, it can kind of mask a disturbance. So even, I don't even care if your blood is 7.40, you still have to check because these can have significant side effects if you don't treat them or at least acknowledge that they exist. So the first question is it acidosis or alkalosis? And we need to be able to determine if it's a respiratory or a metabolic cause. And just once again, a metabolic disturbance is not specified. It could be liver, it could be GI tract, it could be renal. A lot of times it's renal, but it's not actually specific. It's just something other than the lungs. We know that for respiratory disturbances, we will be able to detect the abnormality in abnormal levels of CO2. So for me personally, the CO2 is always the first thing I look for. And then I'm like, well, if it's not a respiratory thing, it must be a metabolic thing. And that is going to be determined by an abnormal level of bicarbonate. So in that way, you can kind of tell what's the problem. For respiratory acidosis, we're looking at blood pH that's less than 7.35. Remember, lower numbers are acidic, and that means your concentration of carbon dioxide is greater than 45 millimeters of mercury. And you know that from this reaction. So if you think about a high level of CO2, it's going to push to the right and then form the acid and the bicarb. And it's the acid that we're worried about here. A lot of the causes of respiratory acidosis are going to be from compromised gas exchange. So fluid in the lungs, I don't know, like there can be a lot of things in the lungs, just lung breakdown of surface area with emphysema or mucus or, I don't know, just something making it hard to get that carbon dioxide out of the body. With respiratory alkalosis, we're looking at a higher than normal blood pH. That means our CO2 levels are below 35 millimeters of mercury. So again, on that reaction with lower CO2 levels, it's going to pull the bicarb and the acid towards the left, and that pulls some of the acidity out, which makes it overall more alkaline. Now, usually this is associated with hyperventilation, but I will say I do think anxiety is a real thing. I wouldn't consider it necessarily pathology, but I do think it's important to get to the root of the cause and help someone calm down, especially if they're in some kind of a crisis. But a lot of times that can be like a behavioral remedy rather than like a medical intervention. For metabolic acidosis, same thing, we're looking at acidic blood pH levels below 7.35, but in this case it's because there's not enough bicarbonate. So that can come from too much acid, and ketosis in like a very protein rich diet does produce more metabolic acid. Alcohol actually gets degraded by the body's liver into an acid byproduct. There's lots of ways like diet can cause a lot of acid. You'd have a hard time eating too many lemons if that's kind of what you're thinking. It's more just like protein breakdown, like starvation can definitely do it. Also, if you're losing bicarb from inappropriate loss, like through diarrhea, Maybe kidney failure too could do it, but diarrhea I think is a little bit more common for a normal person. If you're losing all that bicarb that the large intestine should be reabsorbing, then you could have like a little bit more acid as a result, which could totally create metabolic acidosis. Metabolic alkalosis is going to be a high blood pH, and that is in this case caused by excessive amounts of bicarb. So too much bicarb is just going to like combine with all that acid and then push towards CO2. Now, you could sort of like the alternative we just talked about, have some kind of loss of electrolytes, and in this case, like vomiting stomach acid. Like if you lose too much acid and you just have too much residual bicarb, that could do it. People who take antacids for like calcium or heartburn or something, that is almost all sodium bicarbonate, which means you're going to be ingesting a ton more bicarb than you need. Or another common thing is constipation, and a lot of pain meds actually do cause constipation as a side effect. So the longer that fecal material is in the large intestine, the more water and bicarb is actually absorbed from it, and that can actually create a pH disturbance. And I will say, alkalosis makes you feel sick. So like this is not just a little thing. Like this can really exacerbate like how someone is experiencing some kind of a problem. So the effects here are catastrophic. And I would just say acidosis and alkalosis can both kill you. One will sort of depress you from like not being able to fire your nervous system, that's acidosis, and alkalosis will actually overexcite the central nervous system, but they're both bad, right? Like this is something that really is a pretty small chemical range. So if it's that bad on either side, it makes sense that the body is going to have compensation mechanisms that will help counteract any sort of a disturbance. And of course, it's okay to have diarrhea or vomit or take some Tums once in a while. You just have to be able to like neutralize that and return to, your pH homeostasis as quickly as possible. So the respiratory compensation, you just change your breathing rate, right? You can totally change the number of breaths you have per minute to alter the amount of CO2 that you're releasing. So you can either breathe faster, or I don't know if it's a super hot idea, but you could, I guess, slow down your ventilation for like retaining more CO2 if you needed to compensate for some kind of alkalosis. With renal compensation, of course, that's going to take more time because we've got to like kick up the kidneys and maybe have some hormones there or feedback mechanisms. It's going to be slower. But the thing is, it is always going to be a compensation system for the other area that is the problem. So, for example, if you have a respiratory problem like pneumonia, you can't have respiratory compensation because your lungs are the actual problem. So the renal system will compensate for the respiratory disturbances. The respiratory system will compensate for the metabolic disturbances. And like I said, it could be a renal problem, but it might not be. It could be a lot of different organs. So for determining blood values, we do look at arterial blood gas values, and I think it's important to look at pH first. The other two steps, do what's right for you, but my first instinct is always to be like, okay, what's the pH? Are we talking about a problem here? Is it below 7.35? It's acidosis. Is it above 7.45? It's alkalosis. And then for me, my next go-to is CO2, just because for me, that's the easiest. High CO2 makes acid, so that's acidosis. Low CO2 makes alkalinity, so that's respiratory alkalosis. And then I just kind of have to think about the bicarbonate ones, but you have to check them both. Even if you have diagnosed the cause of the disturbance with just CO2, you still have to look at the bicarb levels. So it's always a question of what's going to be the cause and what's going to be the compensation. So let's do an example. If we had the following blood values, pH 7.55, CO2 24 millimeters of mercury, and bicarb 24, first question is this an acidosis or alkalosis? And 7.55 is high, so that is consistent with alkalosis, right? Now we have to figure out, well, what's the cause of that? And I always ask myself CO2 first. I'm like, well, what is a cause of alkalosis? Would that be low CO2? Yes. And according to this data, 24 millimeters of mercury is below normal. So this is consistent with a respiratory alkalosis, but I can't stop because I need to double check for compensation. So I'm going to look at the bicarb levels anyway because it would be in that system the abnormality for compensation. And it looks to me like bicarb at 24 milliequivalents is right in the middle of the normal range. Compensation is not occurring. Let's do another one. Case study number 2, we've got pH 7.37, CO2 22, and bicarb 12. Now, the first question is acidosis or alkalosis. And you know what? This is in the normal range, isn't it? Like 7.37 is kind of in our normal range, but we can't stop here because with compensation, a patient could have a disturbance and be hiding it from you, and you'd be really in trouble if you miss this. So even though the pH is in the normal limits, we still have to check. So let's see if the CO2 is abnormal. Now the CO2 is very low. Now that would be consistent with a respiratory alkalosis, right? Because low CO2 is alkaline. And even though this pH is in the normal range, it's kind of a little bit more on the acidic side. So that doesn't really make sense. It's not consistent with respiratory acidosis. So it's abnormal though. That's probably because compensation. So let's look and see if we can find the problem in the bicarb. So the bicarb is below normal, actually quite a bit below normal, and that makes this consistent with a metabolic acidosis. And yes, compensation is occurring to mask the problem. Now, I've been talking about these metabolic disturbances being like, well, it could be anything. Well, I want you to know that there's a way to calculate what the actual problem is, if it's liver or kidney or whatever. And it's something called the anion gap. And you will not be calculating this until you go to medical school. And for some of you, good luck with that. I think it's going to be really fun for you. Anyway, I thought I would just make a note of it, that we can calculate it. It's not like we have a mystery on our hands, but that's done by medical doctors and not necessarily therapists and nurses and all that sort of stuff. So hold on to your hats. There's still more for you. But I do think it's good to know the treatments. So for respiratory acidosis, remember that's an inability to get adequate gas exchange. We want to basically not only treat the underlying condition, like if it's pneumonia and they need, antimicrobial therapy or something. We can put them on a vent. We can give them steroids to dilate their airways. More gas exchange is the answer to their problem. With respiratory alkalosis, like I said, this is not typically associated with pathology, hyperventilation. Usually what we want to do is just help retain more CO2, which a lot of people can't just stop breathing, but breathing into a paper bag can actually help calm them down and relieve some of those, when you hyperventilate, you get a little lightheaded and dizzy and you just kind of, sometimes I feel like I want to puke. That's that feeling that can kind of exacerbate the anxiety of a situation and create more hyperventilation because you're all stressed out. So even though breathing into a paper bag does carry with it some risks of hypoxia, sometimes just getting a few extra CO2 loaded breaths can just make someone start to feel better. Anyway, I also think you should help them calm down. Metabolic acidosis, we can administer sodium bicarb, but I will also emphasize that you want to treat the underlying problem, like whatever it is that's creating that acid, like protein destruction or protein digestion, that kind of acid accumulate, or alcohol or whatever, that needs to be treated. With metabolic alkalosis, I will say in rare extreme cases, we can administer intravenous acid, which is ammonium chloride, but doesn't that sound dicey? Better to fix the problem. Better to fix, whatever the underlying issue is that is driving the alkalosis and then revert to acid injection as a last resort, right? All right, now this is actually a page from the Mount Hood electrolyte imbalance chart, and I've edited this chart in the way that I've only shown you potassium and sodium. Now, your book is going to go through calcium, magnesium, phosphate, chloride, dot, dot, dot. But I will say those electrolyte imbalances are much more rare. So, the ones that I think you're going to see a lot are sodium and potassium disturbances. And I want you to know the normal range. One of the things that I've always found kind of helpful about the ranges here is this pattern of threes and fives. Like, you know, pH is 7.35 to 7.45. Potassium starts at 3.5. Sodium is 135 to 145. I don't know. I'm kind of a number pattern geek, and I've always kind of found that sort of helpful. But what I need you to look at is not only the normal range, but what the causes are for either a deficit or an excessive amount of potassium and sodium. And a lot of these are going to be, dehydration, but there's actually some ways that you can explain different types of symptoms, like, cardiac arrhythmia, for example, high blood pressure, as an electrolyte imbalance rather than a cardiovascular issue. So this will be one that I will want you to refer to in the lab case study quizzes, which is just kind of applying this knowledge. But I guarantee you that these electrolyte imbalances will come up for you in the future.